Hyperprolactinemia. Etiology and pathophysiology. Varying degrees of hyperprolactinemia are found in an array of physiological and pathological states. Table 20. Prolactin inhibits hypothalamic gonadotrophin-releasing hormone, GnRH, secretion and hence gonadal steroid production. Epidemiology. The incidence of prolactinoma has been estimated at 25 to 30 per million per year, with a prevalence of 500 per million. Microprolactinemas are diagnosed much more commonly in females, typically in the age range 20 to 30 years, and account for approximately one-third of all cases of secondary amenorrhea in young women. Macroprolactinemas show no major gender difference. Clinical presentation. Females typically present with oligomenorrhea and amenorrhea and/or galactorrhea. Some are referred with infertility. On questioning, they may report symptoms of reduced libido and vaginal dryness with dyspareunia. Males commonly present with larger tumors, macroadenomas, causing local pressure effects, e.g. headache or visual disturbance, although reduced libido and potency, subfertility, and galactorrhea may occur. Physical signs. Always examine for visual field defects, bitemporal hemianopia, and check for galactorrhea. Signs of other underlying disorders, e.g. chronic liver or renal disease, may be present. Investigation. Prolactin. The finding of an elevated prolactin level should be confirmed on at least one separate occasion. A prolactin concentration in excess of 5,000 μ/L usually indicates the presence of a prolactinoma, whilst values up to this level may be seen with many of the other conditions. Pituitary stalk compression is typically associated with a serum prolactin less than 2,000. Prolactin levels in excess of 10,000 μ/L are usually indicative of a macroprolactinoma. Routine blood tests. Check renal, liver and thyroid function and carry out a pregnancy test if applicable. Follicle-stimulating hormone, luteinizing hormone, and estradiol may be useful in the differential diagnosis of oligomenorrhea and amenorrhea. Radiological imaging. Unless there is an obvious explanation for mild hyperprolactinemia, an MRI or CT scan of the pituitary fossa is indicated in virtually all cases. With modest hyperprolactinemia, although a microadenoma may be identified, the principal objective of the scan is to exclude tumor and infiltration causing disconnection hyperprolactinemia. Visual fields pituitary function. Formal assessment of visual fields and anterior pituitary function may be indicated, depending on the clinical and MRI findings. Treatment. Hyperprolactinemia not associated with a pituitary tumor. Drug treatment causing hyperprolactinemia is sometimes amenable to change, in liaison with the original prescriber, often a psychiatrist. Some of the newer antipsychotic agents, e.g. quizapine, are much less prone to inducing hyperprolactinemia. Women with unwanted postpartum galactorrhea, and their partners, need to be advised to avoid nipple stimulation completely for a while, including checking to see if it is still happening. Bromocriptine can be tried, although some women find the benefit and side effect profile unfavorable and discontinue treatment. Underlying renal or liver disease requires appropriate treatment. Idiopathic hyperprolactinemia. Dopaminergic agonists are often effective in restoring prolactin levels to normal in symptomatic patients. NB. Long-term side effects of bromocriptine. Both bromocriptine and cabergoline have been linked with fibrotic disorders, cardiac valvular, pulmonary, and retroperitoneal, when used at higher doses for a longer period of time. While these seem to be rare in patients being treated for hyperprolactinemia, continued vigilance is advised in those likely to have significant drug exposure over time. NB. Mood and behavioral changes with dopamine agonists. Hypersexuality, impulse control disorders and gambling have been linked with dopamine agonist therapy, and all patients, and where possible their relatives, should be advised to report any concerns immediately as treatment discontinuation may be necessary. Hyperprolactinemia caused by a pituitary tumor. Prolactinomas are unusual amongst pituitary tumors in that the primary treatment for both microadenomas and macroadenomas is medical, providing there is no immediate threat to vision. Dopaminergic agonists, e.g. bromocriptine, cabergoline, are often highly effective in shrinking tumors, relieving symptoms, and preserving or restoring anterior pituitary function. The side effects of bromocriptine, including nausea, hypotension, nasal congestion, and fatigue, can be minimized if the patient is started on a very low dose and advised to take the tablet with a snack at bedtime. Unfortunately, due to its short duration of action, bromocriptine requires BD or TDS dosing. Longer-acting preparations, e.g. cabergoline and quinagolide, are therefore preferred in most cases, although again it is best to start with a low dose and gradually titrate up according to the serum prolactin level and tolerability. Even if the patient experiences significant side effects on starting treatment, it is worth encouraging him or her to persist with therapy if possible, as tolerance usually develops over a relatively short period of time. The prolactin concentration is likely to fall with dopamine agonist therapy in either case, and therefore the size of the tumor must be monitored. Microprolactinemas. Following normalization of prolactin, follow-up is on an annual basis unless there is evidence of progression. Treatment may be withdrawn every 2-3 years to check for remission. Macroprolactinemas. For those with macroprolactinemas, serial prolactin concentrations should be checked during the early stages of treatment and a repeat MRI scan performed to monitor the response to medical therapy. Additional bone protection measures, e.g. bisphosphonate and/or calcium and vitamin D therapy, may be necessary in patients whose prolactin concentration does not drop sufficiently to permit restoration of gonadal function. Remember that exogenous estrogens should generally be avoided because of their potential trophic effect on the tumor, although some clinicians will permit estrogen at hormone replacement therapy, HRT, doses once the tumor has shrunk in response to dopamine agonist therapy, and providing that there is no clinical, biochemical, or radiological evidence to suggest tumor regrowth after commencing HRT. Surgical intervention, transsphenoidal adenomectomy, is generally preferred as second-line treatment in the UK. Radiotherapy is usually held in reserve for refractory tumors as it takes time to have an effect and often leads to hypopituitarism. Non-functioning adenomas. Surgery is generally considered to be the treatment of choice. For mid-range prolactin concentrations, 4,000 to 5,000 μ/L, when it is difficult to distinguish between a prolactinoma and a non-functioning adenoma, a trial of bromocriptine or cabergoline may be considered to see if the tumor shrinks in response to medical therapy. Contraception and pregnancy. Women must be warned that they may get pregnant on starting treatment, even before they have a menstrual period. If they wish to defer pregnancy, they should use barrier contraception, although the combined oral contraceptive pill is also safe for use in women with microadenomas. Those with microprolactinemas who do not wish to conceive do not need to take bromocriptine or cabergoline but may require HRT or other agents such as a bisphosphonate to prevent osteoporosis. Again, contraceptive advice should be given. For those who elect for no treatment at all, then close surveillance of bone status with periodic dual-energy X-ray absorptiometry scanning is mandatory if the patient is oligomenorrheic or amenorrhoe. Bromocriptine is safe in pregnancy. There is less experience with cabergoline, although reassuringly there is no evidence that it is detrimental to the pregnant woman or fetus. In contrast, concerns have been raised regarding higher rates of miscarriage and fetal malformation in females taking quinagalide and pergolide, although the number of cases reported to date is small. In general, patients with microadenomas are usually advised to discontinue treatment once pregnancy is confirmed, as there is very little risk of clinically relevant tumor expansion during the remainder of the pregnancy. Most endocrinologists recommend clinical review during each trimester, but it is extremely rare for intervention to be required. Patients should be reassessed following cessation of breastfeeding. With macroadenomas, many physicians recommend continuing bromocriptine throughout pregnancy, with avoidance of breastfeeding postpartum, in view of the risk of clinically significant tumor expansion. In other cases, e.g. those with small tumor remnants, bromocriptine may be withdrawn, but patients should be warned to present immediately should they develop visual symptoms or a severe headache. Close follow-up is required in either setting. Complications. Prolonged oligamenorrhea or amenorrhea is associated with an increased risk of osteopenia and osteoporosis. Disease associations. Prolactinomas may rarely be associated with parathyroid and pancreatic tumors in the context of multiple endocrine neoplasia type 1 syndrome.